Welcome to the Language Testing and Certification Program's Medical Interpreter Orientation. I'd like to welcome Linda Gawley and Ileana Logo, your presenters.
Hello, welcome to this orientation for medical interpreters. Today's orientation has two portions to it. The first portion is the mechanics of medical interpreting. What do you do when you walk into the room and everyone looks at you expecting you to know what to do? The second part of today's orientation is inspection control and industrial safety for medical interpreters. We will begin with mechanics of medical interpreting.
Thanks everyone for joining us today. I just want to preface the entire discussion of mechanics with the clear understanding that the mechanics of medical interpreting address the how-to, the ingredients and the techniques that go into sustaining and enabling really clear, good communication between patient and provider, and not the rules or the ethics or protocols, standards of practice, which is a separate webinar from this one. So this is really the nuts and bolts of medical interpreting, but in both areas, the mechanics as well as in ethics and standards of practice, you always need to remember that you are the communication expert in the room. The patient has their issues that they know the intimate details and need to communicate to the provider. The provider is the healthcare expert that listens to and understands if the communication is properly facilitated and helps that patient get to a better health outcome. But you are the communications expert, and you're the one who can, quote unquote, take the pulse of the situation in the room in order to help facilitate better understanding. You're the first one who's going to notice when the patient is not really getting what the provider's saying, and you're the one who's going to perceive that the provider has never heard of a food, a practice, a tradition that the patient has mentioned as their own self-treatment for whatever their present complaint is. So please have that self-confidence of knowing that I'm the communications expert and I'm going to help these two sides get to the middle, get to trust each other and communicate well with each other. So keeping that in mind, the rest will be very clear how-tos on how to get that done when the three of you are in the room. So we have several learning objectives today, and we'll be repeating them because they're really important for you to remember these areas clearly. We have what is often referred to as the pre-session, which is not a formal event where you print out an agenda and book a room. The pre-session sometimes is just one or two sentences at the beginning, but it helps you align with the purpose of the visit. What's happening in this encounter? Is it a first visit? Is it a return visit for something that the patient is already familiar with? Are they explaining pre-procedural preps? There's a lot of different things that happen in encounters, and if you have an idea of what the point of today's visit is, you will do a better job of interpreting. We'll talk about positioning and reference the traditional triadic encounter positioning as well as the realities of every kind of shape and size and situation that you will confront when you are interpreting. The accuracy and completeness of interpreting will be addressed, what to pay attention to and how to work on those aspects. And a key component, transparency in everything you do to facilitate that communication, particularly when it's not going well, is very important to always keep upfront and visible to everyone, that transparency. How to use interventions correctly when you notice something is going off track, when you yourself are unfamiliar with the term, whether it's a regionalism from the patient or a high register term from the provider. Site translation and the challenges of doing that accurately and smoothly. and how to be alert. What are the signs of misunderstanding and lack of understanding?
So just another quick reminder to follow up on what Eliana just said. There is an entirely different orientation from the LTC program about the Code of Ethics. The Code of Ethics refers to the relationships between the interpreter and his clients, which are both the patients and families and the healthcare team. So we're not going to address the Code of Ethics in this orientation. That will be something you do separately.
Now, we also are going to look at roles differing by placement, which means, particularly for those of you that are independent contractors and are going to a variety of locations, a variety of clinics, different hospitals, each one of those workplaces has their setup and their codes of behavior and their expectations. So in some places, interpreters are expected to simply repeat words back and forth within that assigned encounter and then go directly home. In more and more places, interpreters are expected to be an active and thoughtful part of the care team. What you know about that culture matters and helps aid in the provider's understanding of what's going on with this patient. And what you understand about North American medical care and access to care helps guarantee that your patient gets connected to the care that they need. So it's always important to find out what are the expectations of that workplace that you're going into, particularly if you're working at a variety of workplaces.
So now we're going to dive into the pool, the nuts and bolts. We're going to talk about the technicalities of our profession. These are the topics we're going to address in the next few minutes. What are the modes of medical interpretation? What are the functionalities? And that includes the function of being a conduit and the function of being a clarifier, for example. We're going to talk about what site translation is, when we do it, when we don't, how we do it. We'll discuss completeness. What does that mean? What are the elements of communication so that we know that we got all of those elements and included them all as we interpret? What is accuracy? Is it word by word? Is it meaning? What are the specific elements that you want to take into consideration for positioning, where you put yourself relative to the patient, the family, and the healthcare team members in the room or in the clinical environment? And we will talk a little bit more about the introduction and what you want to include in different situations. As Eliana said, every encounter is different and your introduction will be different based on that. So now we're going to dive in with our first topic.
Consecutive interpreting. This is primarily the default interpreting for medical situations. Yes, you do a little site translation. Yes, in critical scenarios like the emergency room and trauma bay or family conferences, you may do more simultaneous. But 90% of what you do is going to be consecutive. So what does that mean? It means one person speaks at a time. So you actually have time to listen very attentively, very carefully, and in a focused way, and perceive what might be a pitfall, cultural misunderstanding, or what you need to be aware of that you may have to clarify. So you have the time to process what you're listening to, and the conversion is easier because you have that time, the conversion into your target language. You only have one voice to pay attention to, whereas it can be very challenging when there's multiple voices in an agitated state, all shouting out something that you're trying not only to figure out who said it, but what are they saying, can I remember it? One-to-one like this really assists your accuracy and your completeness. And yes, it takes a little bit longer than simultaneous. Remember, everything is being said twice. But it does lead to much better comprehension because there is the time to relay that message. Patient speaks, you carry that message over and convert it to the provider. Provider hears it, understands it, replies, and you carry that message back to the patient. And when you deliver, it's been converted to their language. And it's very much taking turns back and forth, like passing a ball back and forth from the end to the middle to the other end to the middle to the end to the middle, just back and forth. When it doesn't feel that way, when it gets stuck at either end, if you're not transparent about what's going on, there's going to be a complaint that comes out of that encounter. One end or the other is going to feel left out. So make sure that that flow feels smooth and carries to either side on a regular basis. Everybody's going to feel comfortable with that rhythm.
And the interpreter really is sort of handing the ball back and forth from one party to the other party. You can almost think of it as handing something physical back and forth. So let's say I'm the interpreter and Eliana, you're the provider, and I have my patient in the room as well. And you, the doctor or the nurse, says, "I'm so glad to see you today." And as the interpreter, I turn to the patient and I say, "I'm so glad to see you today." And the patient has a chance to think about that and to formulate his or her response, and then says, "Well, I wish I hadn't had to wait so long because I'm really in pain now," and hands that ball back to me as the interpreter, and then I turn to the doctor or the nurse and say, "I wish I hadn't had to wait so long because I'm really in pain now." So it's lovely flow, and each party can watch the other party talking. So the doctor is listening to the patient, watching the patient while the patient is saying what he's saying in his language, which is really great because we want to always direct everybody's attention back to each other, not to us. So even though we're speaking, they can look at each other. Like a game of tennis, like you said, we're the ball boy in the middle. Okay.
And I often train providers because they need that little bit of a nudge sometimes, because it's natural to look at and pay attention to the person you actually understand. I often tell them, use the opportunity while the patient is speaking to watch them, watch their gestures, watch their body language, and then reconnect those images to the talking points that the interpreter delivers to you. And you get a more coherent, three-dimensional picture of what's going on with your patient. And providers who actually attend the training show that they've got the interest to begin with, but that's a tip that they have found helpful because it is just human nature to look at the person you understand as opposed to the one you can't understand. Now, simultaneous is more challenging. It is more tiring, and it is more stressful, particularly if more than one person is speaking. So there's lots of exercises you can do for focus and attention or multitasking. But if you are a parent or if you have an extended family, you already know how to do this. You already know how to listen to several people battling for your attention at the same time. So for simultaneous, that's when very little interaction is expected or permitted. This can happen in the trauma bay in the emergency room where different providers are shouting out questions that you need answers to. And generally these situations are highly charged, either with emotion by the patient's family or the patient, or pain levels that the patient is enduring, and the criticalness of what's happening. So we need everything very quickly. Also, family conferences may be different. It may be an end-of-life conference, but the tension and the emotion in the room is at just as high, if not higher, a level. And you may have several family members shouting out questions or grieving in a way that is loud enough to interfere with the communication that's going on in the room. So we'll discuss some tips and some recommendations for both consecutive and simultaneous.
And let's paint some pictures of some of these situations. Let's say you're the interpreter and you're in the emergency department in a room. There's a patient that is being worked on. There are maybe 2 family members in there as well who don't speak English and don't understand what the care team is talking to each other about in English. So you might be in the corner with the 2 family members saying to them in their language what is being said by the care team to each other in English. They're not talking to the family, they're talking amongst each other, but the family needs to know what is being said, because if they were English speakers, they would know what was being said. Here's another scenario. You are part of a tour of the labor and delivery suite, and you have a family that speaks your language in a larger group of English speakers touring the labor and delivery suite. So you have your family and you're kind of walking to one side of the group or toward the back of the group. And as the tour guide is explaining what happens in labor and delivery, you are transmitting that as you walk along in your language to your family. This can also take place in something like a transplant class where you have many English speakers and you might have several different interpreters in that class all doing simultaneous and going through that transplant class material together in their various languages quietly with their families maybe out at the side or at the back of the room. For this kind of simultaneous, it's a little bit closer to the United Nations type of interpreting, where it is very helpful to know the material ahead of time. So if you know that you are going to be the interpreter in a group setting, if you can get the materials ahead of time and prepare yourself with the terminology, that is very helpful. It might be transplant, it might be a mental health group therapy class, it might be a diabetes teaching class with numerous patients.
So when it comes to medical interpreter functions, the carrying the message or the conduit means you're just carrying the meaning as intact as possible. Imagine that the person, when they speak, is painting a picture. When you convert that message into the second language, the recipient should see the same picture that was drawn by that first utterance. We all know that it's going to be a different number of words, and the words will be in a different order, and that sometimes there may not be an exact word-for-word match. But if that person drew a picture of a house with a front door, 2 windows, and 2 trees, when you convert it into the other language, the recipient should also see a picture of a house with a front door, 2 windows, and 2 trees. So just to be clear, we know that it doesn't take the same amount of words or the same amount of time, but the completeness of the message should be intact at either end every time you deliver it. And we have a way between switching between the message carrier role and the clarifier role, which involves using first and switching to third person. Now, I know a lot of us have run into the problem when we ask a provider, please speak directly to the patient, speak in first person, and they say, sure, and then turn to the patient and say, can you ask her why she came in today? And so I want to be really clear that first person means I, me, and third person means he, she, or it. So as the conduit or message carrier, if the patient says, I have more pain today, the interpreter says to the provider, I have more pain today, not she said she has more pain today. But when the interpreter wants to intervene to ask for a repetition or a clarification, then you have to use whatever your visual sign is. The hands making the T symbol is very popular here in North America because North Americans understand that as time out. Sometimes people put up one finger, sometimes people put up one hand held flat like the stop. whatever your visual cue is needs to be accompanied by a statement in third person so that it's very clear that it's the interpreter asking for something and not the patient's voice or the provider's voice. So it would sound like visual cue, the interpreter wants to clarify, would like to ask you to repeat, would like to double check for meaning. There's a lot of things that you may wish to intervene for. Sometimes the patient is in pain and speaking in a little whispery voice, and it's difficult to hear them. Sometimes they come from an area in the country that uses different regional terms for foods or practices, and you want to double check, did you mean this type of fruit or this type of fruit? Just intervene always with that visual cue and saying, the interpreter wishes to, and then everyone in the room knows, because you also repeat that in the other language, that it is you asking for a clarification. And then as soon as whatever point has been straightened out, you go back to I, me, as the patient's voice. So that's one that I wish we would all use more consistently to help train our providers to understand the difference between first and third person. We should all be using first person when we speak in the patient's voice.
So it would sound like this, maybe. Tell me if I have this right, Eliana. Doctor says, this looks nasty. What did you do to yourself? As the interpreter, I say, this looks nasty. What did you do to yourself? Patient says, I fell off my bicycle. As the interpreter, I say, I fell off my bicycle. The doctor says, well, you shouldn't do that. And I, as the interpreter, am not quite sure what the doctor means by that. What isn't the patient supposed to do? So, as the interpreter, I say, I don't just try to say it to the patient because I'm not sure what the doctor means. So I say, the interpreter would like to ask the doctor, what do you mean when you say you should not do that? And I've just handed the ball back to the doctor. The doctor says, what I mean is, it's great to ride your bicycle, but please don't fall off it next time. Then I step back into my interpreter role, and I just interpret exactly what the doctor just said, and I say, what I meant is, it's great to ride your bicycle, just don't fall off it next time. And you can see that I have stepped right back into my conduit role. So I've gone right back into going straight across, words to words. So that was a very smooth transition. I didn't have to say, oh, thank you very much for clarifying that. You know, I can just go right back. Once the clarification is made, I just pass that ball right back to the patient, and we keep going. Does that sound right?
That sounds right. And this is why we will be discussing these techniques, these tactics, as well as the need for having some prepared ways of doing interventions or any of the things that come up on a regular basis, like a little script the interpreter wishes to clarify, or a little pre-session script. Hi, my name is Eliana. I'm your Portuguese interpreter. Please speak directly to each other and know that everything that's said will be interpreted and kept confidential. There, 2 sentences, and I just squished a lot of stuff in there. Have things that work for you, but that are succinct and clear so that you can traffic cop these conversations efficiently. If there's too much meandering and too much anecdotal storytelling, the providers will get impatient. But if you're succinct and clear and professional in managing the flow, the providers very much appreciate that.
Absolutely. We're going to touch on something which is a little bit tricky. It's called sight translation. What sight translation means, this is half interpreting and it's half translation. Now, when we talk about translation in the language support professions, we mean written documents. When we say interpretation, we mean spoken language. Sight translation is halfway between the two. As the interpreter, you may be asked to read something in English. So you're reading a pill bottle or you're reading a page of information, and you are asked to say that to the patient in the target language. Or it could go the other way. The patient may bring documents in his own language to the encounter, and the provider may say, okay, you have the hospital discharge summary here in Mandarin. Interpreter, would you please translate that for me right now? Just tell me what it says. And they want you to read this 3-page document and speak it to them in Mandarin. In English. You're supposed to read it in Mandarin and speak it to them in English. We have rules about this in medical interpreting. As a medical interpreter, you are not required to even know how to do translation. It is a different set of skills. And we actually strongly discourage site translation beyond very, very short pieces of written material. And by short, we mean maybe 1 sentence or 2 sentences. So it is fine if you are literate in your non-English language, and if you are literate in English, you feel comfortable with the written English language, it is okay to read very short pieces of information, especially if that information has already been gone over once before by the provider directly to the patient. So for example, if the provider has discussed a medication with the patient and there are 3 pill bottles out on the desk and the patient says, so okay, interpreter, which one were they talking about? And you pick up the pill bottles and you say, this is the one that they just talked about, and it says take 3 at bedtime. That's okay because you are reading specifically right off that pill bottle, but you are not explaining anything. You are just reading something very, very short. Beyond that, we do not do this as medical interpreters. Very often, you will be handed a long document and asked to explain it to the patient or to administer a consent to the patient, and the doctor or nurse tries to leave the room. This is where you immediately hop up out of your chair and you say, excuse me, doctor, nurse, as the interpreter, what I need to do is assist you in presenting this information to the patient. I will interpret what you say to the patient as you explain this content to the patient.
And this avoids the pitfall of being asked questions. Remember, we're never supposed to answer medical questions, give recommendations, or advice. We are there to interpret the communication between the patient and provider. And I know that it is a temptation with how busy people are and how overburdened they are to slide a responsibility that really belongs in the provider's lap off to the interpreter and say, here, go through this 30-page document with the patient. No, I will interpret for you as you, provider, go through that 30-page document with the patient. That's just best practice, and that keeps us clear of any sort of risk and keeps the roles clearly limited to what they should be. The provider is the one who gives healthcare guidance and advice or recommendations, and the patient presents with their symptoms and their history, and we facilitate that communication back and forth. We are not the tour guide. We are the interpreter. So it is a delicate one, and this is another situation where I strongly recommend having a script, not a 2 or 3 paragraph explanation, but just like we have on the page, a single sentence that says, please, doctor, if you would present this information to the patient directly, then I can interpret for you.
Exactly. And one thing that comes up for us all the time as medical interpreters where you can get into trouble is helping patients fill out forms. Because there again, we're dealing with written information on a page, and the provider or care team member may not be in the room, and we're expected to go over that form and have the patient fill it out. Now, where we get in trouble is when we're tempted to go past just telling the patient what the question on the form says, and we explain what the question on the form is. For example, if you're going over the family medical history page on the intake form with the patient, and you're reading, is there any family history of, and you list all of these 20 different conditions in the target language for the patient, and you get to one that the patient doesn't understand what that term is. For example, angina, heart pain. And the patient has never heard of this term in his language, and he says to the interpreter, well, what does that mean? At that point, we get in trouble if we then are tempted to explain what angina is. So, to stay out of trouble and to not start explaining medical terms, what we do is we say, I am going to put a question mark on that space so that when the provider goes over that form with the patient later on in the encounter, the provider can explain it to the patient and can go over that and can elicit that information, him or herself.
So back to nuts and bolts. Basic to all of this, fundamental to all of our being the traffic cop for communication, is everybody understanding what is being said. So what do we do? What can we do to facilitate that understanding? One of the first things we can do is have more than one register available to us in our synonym dictionary in our head. We know that often patients don't understand the high register term, but may understand a simpler version of that word, like infarct versus heart attack. And it is our job to help the provider adjust their register by pointing out that there may be lack of understanding, rather than assuming that this is what's going on and choosing to edit the register without sharing that information with the provider. Again, the first-personness, if that's a word, sticking to first person when you're speaking in the patient's voice. Completeness, accuracy, and all of the above lead to understanding. And when there is any doubt, you check for understanding. If you're not sure, you check for understanding. Even if you think the patient probably understood, check for understanding. Even if you think the patient did understand, it doesn't hurt to check for understanding, because when you get that confirmation back, that's when you can really say, yes, they understood, as opposed to, I'm pretty sure they understood.
And then it's mission accomplished. So we have understanding in this set of what we need to be looking for, and I just want to point out that we're going to start with making sure that we as the interpreter understand first. After that, we're going to check for understanding on the part of the parties that we're helping. We're going to check to make sure that the care team person understood what the patient is trying to say. We're going to make sure that the patient and family understood what the care team was saying, but none of that can happen if we don't start with our own understanding of what is said. And all too often, I think that we skip over this as medical interpreters. We find ourselves in the middle of an encounter. Everybody has something to say. The pace is moving along. The river is flowing. And just like in a conversation in our own family, sometimes you hear people talking and you're not quite sure what's going on, but you don't have any responsibility for that in your family conversation. Well, guess what? As the interpreter, you have to be super aware of, oh, I'm not really quite sure what he did mean when he said that just now. Now we're in a medical conversation where it could be absolutely essential to stop that flow. Yes, it's uncomfortable, but that's what you're there for. Your job is not to have people feel nice and cozy that there's a good flow going along. Your job is to make sure that you completely understand what is being said before you interpret anything. Now, Ileana used the word register. Register means the complexity of the language. How complicated is it? How technical is it? How unusual is it, or how different is it from normal everyday conversation? I have been in conversations as the interpreter where I was very uncomfortable with the register that the nurse was using in going over discharge instructions with a patient. I was having trouble understanding the abbreviations that she was using, and I'm thinking, wow, the patient is probably not going to understand these abbreviations either. I'm in healthcare, and I don't understand her abbreviations. So I was putting up a red flag to myself saying, oh, I better double check with the nurse. She used some abbreviations here. I'm going to ask her what she meant to please lower the register, which means say that in a less technical manner, and then I can interpret it straight across to the patient once she has explained that. So the most dangerous thing for an interpreter, medical interpreter to do, the most dangerous thing for the patient is when we guess. We think we know what the care team person said or means, but we're not absolutely sure. So yes, we are asking you to clarify maybe more than you are used to doing, because our standard is higher. We need to hold ourselves accountable for making sure that we truly understood, so that when it comes out the other end of our conduit in the patient's language, it's absolutely clear. And this is true for going from the patient to the care team member as well. Think about having the patient give a long story about what has happened to him. Very often there are pieces to that story which are not linear, and we're not quite sure whether something caused something else or whether it was coincidental. We're not quite sure what the connection is there. It is important for us, before we try to interpret that into English, to clarify that. And we'll just remind you how we do that. We do that transparently. So the patient says something I'm not sure about as the interpreter. I'm going to say quickly to the provider, the interpreter is going to ask the patient for clarification of the storyline. Then I turn to the patient and I say, please clarify what happened before what. I'm not sure which piece of this happened first. And I hand it back to the patient. So the provider is not wondering what the side conversation is that I just had with the patient. The provider knew exactly what I was doing. So when it comes back, it will be clear to the provider that he is getting a more clear picture of what the patient was originally trying to say. Many times we find ourselves in medical situations where we ourselves are not experts on the content matter. For example, you might be in a mental health setting, or you might be in a pediatric setting where they are discussing immunizations that you are not completely familiar with. It could be in any setting that something comes up that you personally are not clear on what that is. We have a way as medical interpreters for asking the provider to explain that. And one of our favorite ways of doing that is to say, as the interpreter, I would like to ask the provider to break down that term so that I can interpret that for the patient. So we are giving the doctor information about the fact that we are not familiar with that subject matter, which is a good reminder to the provider to then speak very clearly and carefully and using less technical terms, because if we don't know it and we're the medical interpreter, quite possibly the patient will need it explained in more clear, down-to-earth, normal language as well.
Now, it's really important we're clear here about when to recuse yourself. In the ethics piece, we talked about your own internal judgments, religious-based, upbringing-based, community-based, gender, minority, sexuality-based, whatever they are, they stay inside, and they're not supposed to impact who you provide service for. You can't choose, I'll interpret for the victims of the DUI driver, but I will not interpret for the DUI driver. No, you have to be willing to interpret for all comers. However, when it is this situation, now over to mechanics and nuts and bolts, when you do not have the vocabulary, the competence, the knowledge to adequately perform the task, you must self-identify. So I know I can't interpret for anything involving jet engines or boat engines or car or truck engines. I don't know anything about how engines work. And if the conversation were to go in that direction, I would have to say the interpreter does not have the terminology or training to do a good job interpreting for this conversation. That's different than I choose not to interpret for this person. I don't know how to interpret for the jet engine conversation, so I have to flag that. And you also can't be shy, and this is one of the, for lack of a better word, one of the ickiest situations to be in, when you have a great deal of difficulty understanding the provider's English as a second language pronunciation. There are certain language groups that I struggle with more than others because of my own immigrant background, Latin-based language accents I barely hear. Because I was married to somebody from Irish descent, I get those British Isles accents. But I have more trouble with Korean accent or Vietnamese accent, and I will self-identify and say, it's me, I'm having trouble with your accent, please forgive me, but could you slow down or speak more clearly, space out your words. It's my difficulty. I don't put it on the person. But you also have to be clear. If I don't understand what the provider is saying, wherever they're from, it doesn't matter how good an interpreter I am because I can't carry that message over to the patient. So you have to be brave enough to out yourself and say, I'm sorry, I lack the filter needed in order to really understand you as fully as I need to do a good job as an interpreter. And sometimes you can work together to resolve that, and sometimes it's not fixable in that moment. But these are the realities. We work with people from all over the world, and sometimes that accent is a challenge for the interpreter.
I love the way you said that. That was so diplomatic. When we can put it on ourselves instead of putting it on the patient or the provider, instead of saying, I don't think the patient understands this, if we say, would you as a provider say this more clearly for me, the interpreter, so that I know that I'm saying it correctly, it puts it on me, and then reversely on the provider, we don't want to make him or her sound like she's got a horrible accent. We just say, I'm not familiar with listening to folks with your accent. Please help me out, and you can do a little smile and grin, you know, and it's on me. I love that. So we're going to talk, we've just talked about register. We can go forward with that. So let's skip over to talking about first person a little bit more and why medical interpreters use the first person. We used to, when we used to take our neighbors down to the doctor's office and help them out, or when we took our grandmother down to the doctor, we used to say everything in the third person. So if I were the granddaughter, I would say, my grandmother wants you to know that she's been having a lot of trouble eating lately. And then the doctor would say something, and I would say to grandmother, the doctor says that, you know, it would be really good if you could change your diet and do this, that, and the other thing. So we were saying he said, she said, as though they were in a different country, not sitting right there next to us. So we have very clearly changed over to using the first person right now. The main reason that we do that is to preserve the voice of each of the parties so that it is more authentic, and the person who is hearing us as the interpreter is actually hearing much more closely the voice, the tone, the authentic voice of the person who was speaking, so that the patient can hear the concern coming from the healthcare provider, and the healthcare provider can hear the anguish or the question coming from the patient. So it actually allows the message to go across much more cleanly and authentically if we use first person. It's also a lot faster because we don't have to add all of the extra words in there. He said that, blah, 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 and it gets grammatically quite complicated for the interpreter also trying to do the old third-person way. So if we just get in the middle of that flow and let those words go right through us with the original person's voice, so it comes out as I, it makes for a much more direct communication. And what we need to do as the interpreter is constantly support that relationship between the patient and the provider and the patient. There are a few situations where you do need to come out of the first person method, but these will be very far and few between. Occasionally, in a language where either the gender or the status is built into the language to the point where if the interpreter tries to speak with the voice of either the patient or the care team member, it sounds so out of sync with the interpreter's gender or social status, then it's okay to change to third person, but that is not the case for most languages. So really, plan to use first person almost always. The other exemption that we recommend you switching to third person is in cases of sexual abuse, for example, if the conversation becomes so personal that the interpreter has trouble actually expressing the pain or the fear of the patient, it is okay to say the interpreter will now use the third person, and that cues the care team that you've done it and that this is a very difficult conversation for the interpreter to be interpreting for. You can do that, but again, this is far and few between.
And situations that qualify for that would be, like you said, sexual assault, particularly if it's sexual assault of a minor child.
Torture.
People relating stories of torture or imprisonment. The toll it takes on the interpreter is something that every interpreter needs to be mindful of when you tell those stories in first person. And then the soldier slashed me with the machete and threw my baby on the fire is something you will go home and have nightmares about. So it's not a day-to-day occurrence, but it is a technique you can use when you realize that the content is so horrific that by using that first person, it also becomes a little bit more part of you. And sometimes you need to, for self-care, put a little bit more distance so that it doesn't
overwhelm you.
Overwhelm you, that's a good word, Linda. Now, completeness. We want to make sure, like I said before, that the picture that's painted is the same picture that is seen at the other end of the communication. So what can you do to assure that you don't miss anything, that you don't leave one piece out of the communication? Try to listen to the speech in chunks. There's a reason why telephone numbers have that hyphen. because we remember chunks of information better than the big long string of 10 or 13 numbers. Area code, exchange, and then number helps us to remember it. So chunking up the content in your mind or as you take notes can help. The way you take notes can help. There's lots of available training on note-taking. But if I am taking a history, for example, I might change my note-taking paper from profile to landscape, which means turning it 90 degrees so that it's extra wide, so I can put things that happened a long time ago on the left side, and things that happened not so far back in the middle, and things that are going on right now all the way over on the right-hand side, because people don't tell their story in a lovely, well-written, coherent, chronological way. They tend to jump all over the place. One thing leads to another, and it pulls out another memory. So that's one thing I do to try to keep what happened and when it happened clear. I know what my weaknesses are, and my weaknesses are proper names, particularly if they're not Latino names. I can remember Maria de Lourdes de Conceição Ferreira Alvarez, but I can't remember Jenny Jones sometimes. So I write down what I know I'm not good at. That's going to change for each one of you. So know where your limitations are. And I have a little trick that I do for multiple items. If the doctor is giving a long list, okay, so today when you leave, I want you to stop at the desk and make an appointment to return in 3 weeks, and then go get your prescription filled, stop at the lab and get your blood work, and make sure you set up that referral appointment. Well, I have just opened 4 fingers on my hand. And then when I turn and tell the patient, stop at the desk and make the return appointment for 3 weeks, I close 1 finger. Fill your prescription, I close the 2nd finger. Go to the lab and get your blood, and then there's 1 finger still open. I'm like, and I can go back and check with the provider. Oh, yes, and make sure you get your referral appointment. So it's a way to immediately identify that there's still an outstanding item. It doesn't mean you have to do this, but there are just little things that you can do to make sure you stay on track with accuracy, whether it's note-taking or the finger technique or just working on your memory or focus and attention. We want to make sure that nothing slips through the cracks. If we don't hear it, we don't carry it over to the other side.
We're going to talk about accuracy. You know, you can tell somebody who's flying an airplane not to crash the airplane, but that doesn't really give that person specifics on how to not crash the airplane. And everybody tells interpreters, you must be accurate. Well, how do you be accurate? What do we mean by being accurate? So that's what we're talking about right here. We add nothing. As the interpreter, we do not add anything to what either party said. Nothing from our own head should be added into that unless we tell both parties that we just added something to it, and we call that owning it. So in general, we add nothing, and we omit nothing. Let's say the patient says something 3 times. We say it 3 times. Let's say the provider says something 3 different ways. We say it 3 different ways. Or if we don't have 3 different ways to say it in our target language, we say it 3 times because the provider wanted the patient to hear that 3 different ways, 3 different times. We omit nothing. We make no judgment about whether something is important or not. We put it in there anyway. If one of the parties said it, we say it.
And this is an area where I often see family members and friends in a misguided attempt to assist summarizing what the patient has said. And this is a complaint from providers. They say, what brings you here today? And grandma tells a long story about the pain that started in her neck and traveled down her back, and now her leg was bothering her, and then 2 weeks ago she hurt her knee, and it goes on. And then the family member or friend turns around and says, she has a pain in her knee. Well, the provider knows that there's a lot more that went on, and they hate that. So please, whatever the patient says, even if you think it makes them sound less than whatever adjective you want to fill in, educated, cultured, savvy, it doesn't matter. You have to carry that message. That picture that was painted, even if it's a broken down house with no trees, you carry that picture over to the other side.
And if the patient doesn't express himself clearly, that better come out of our mouth as the interpreter as not clearly. Because how's the provider going to know how well that patient is processing language if the provider doesn't hear what you hear as the interpreter from that patient? If it's disjointed sentences, if it's incompleted thoughts, especially if the patient says things that contradict each other, that happens all the time. The patient will say this, and then he'll say something that contradicts it 2 sentences later. We better not mess with that. The provider needs to hear that the patient said contradictory things or things that didn't make sense at all. Super important for the provider to hear exactly what the patient is saying.
And this includes bad language. This includes racist statements. This includes anything that the patient says. And I know this is a sticking point for some people. You can't censor it and say the patient just said a bunch of bad words, because already you're not using first person. They have no idea what was being said. Trust me, when there is an English-speaking patient and an English-speaking provider, and it's a mental health appointment or it's the emergency department, if something hurts and that patient swears, he does it in front of the provider knows what they said, and it is valuable communication. So it's not up to us to decide what to spare the provider from hearing, and vice versa.
Exactly. Now, taking another slightly different look at this picture of accuracy, very often one language uses certain words to convey a meaning, and you can't just transfer that over to the other language. It doesn't translate to the other language. So, for example, if the patient says, "Call me a chicken, but that surgery sounds scary," and I hear that as the interpreter, I know what it means. It means, well, you might think that I'm not very brave, but I'll tell you, that surgery sounds scary to me. So the meaning of what the patient is trying to say is what I need to bring over to the provider. Very often our providers use terms like, "Oh, you're batting 1,000. This is great. I won't need to see you for 3 more years." We know that this patient doesn't understand baseball, or we think that it's possible the patient doesn't understand baseball terminology. Certainly the language doesn't have those terms in it, but I know as the interpreter what the provider is saying is, you are doing very well in what we were hoping you were going to do well in. Everything is going well. And that is what I turn and say to the patient. If I'm not sure what that little phrase meant, then I'll clarify that before I interpret it. But we don't say it word for word, because word for word it wouldn't make sense in the other language. We need to take the meaning of it and then take that meaning across.
Colloquial expressions are always a challenge. In my country, Brazil, blue is a happy color that you wear for good luck on New Year's Eve. It does not mean depressed. We don't sing the blues in a sad way. So if someone asks, "Are you feeling blue?" that sounds very odd. I know what they're asking. Are you feeling depressed? Are you feeling sad? But the feeling blue, we don't feel a color in Portuguese. So there's many, many things like that. And when I train providers, I ask them to try to be really boring and direct in their speech. And it's hard because these colloquial expressions, when you use them, you know what they mean, so you don't think that they would be a challenge to somebody else, but they are sometimes the trickiest thing. Patients will wake up, post-surgery in the recovery area and say, how am I doing? And the nurse will say, oh, you're out of the woods. And they'll look at me and they understand a little bit of English and the horror in their face. What was I doing in the woods? It's not the communication that the nurse was trying to impart. She was trying to say, you've gone beyond the critical phase and now you're stable, which is a much better message for the patient to hear.
I love that example. That's beautiful. Tough talk. Lay it on us, Ileana.
All right, tough talk. Sticky situations, like having a provider with a strong accent. Remember again, like I said at the beginning, you are the communications expert. There will be times when you sense that things aren't going well, despite your best efforts, or there will be times when you know you're the problem. I don't know what that word means. I don't know what the patient just said. I don't know what that term that the provider just used means. Don't be afraid to traffic cop and manage the situation. You have to be alert to when the breach begins to open and everybody's going to fall in. So what is the key to helping the parties stay in good communication and build that trust bridge? It is managing that misunderstanding or that clarification in a way where nobody feels left out. Whenever someone feels left out, there will be a complaint afterwards. So yes, you understand that the patient maybe is lost, and from their description, you understand where they are in the facility. Before you start to explain how to arrive correctly at the clinic, you need to tell the provider, I need to assist this patient with wayfinding, and I'm going to explain how to get to you on time if they're on the phone together or if you're on the video together. Or you just are proactive in letting the person who is not going to be part of the discussion, that there's going to be a brief discussion now for me to get clear on what I need to communicate to you. Just bear with me for a moment, and then you turn to the provider and say, that's a term I'm not familiar with. Can you repeat the name of that medicine? I've never heard it before. How do you spell it? Because I know I'm going to do my homework when I get home later and look it up. But you get through whatever that snag is, and then you turn back to the person who has been waiting, whether it's the patient or provider, and thank them for waiting and say, here is, and then speak in first person. Okay, I understand. This is what needs to be communicated. And then you go back to first person and say what it is. You have to do that alert prior to all of that side communication. Otherwise, people feel left out and then they get angry. Whereas if they know you're just trying to get a better, clearer explanation for them, they are very willing to be patient and work with you. But if they're excluded from that, here's what's going to happen, then it generally doesn't go well, even though you teased out the information that was needed. So please, please be transparent. And what does that mean? That means alerting all parties that, oh, we need to stop for a moment so that I can be clear on what this word, term, phrase means, and then repeat that in the other language, and then go dig out the information that you need, and then thank everybody for waiting and getting that answer. So it sounds way more complicated than it is, but if you just do it up front, you have much better results than if you skip that step.
And this is a really critical point about medical interpreting and how it is different from court interpreting, and it is different from conference interpreting. In medical interpreting, the goal for everyone is that the patient does well. This is not adversarial. There aren't parties fighting against each other. In the medical situation, we want to make sure that all of us take responsibility for making good communication happening. That's why the medical interpreter is charged with being alert to misunderstandings. In the court system, the interpreter has no responsibility for trying to figure out if anyone understood anything. As long as the interpreter does the interpreting, that's all he is supposed to do. He's not supposed to check for understanding on anyone's part. This is different in medical interpreting because we don't interpret just to check off a box that there was an interpreter there. We want to have the interpreter there so that communication is full, complete, and accurate.
So that transparency and then that verification and checking for meaning is critical so that you do not add to any misunderstanding. You are keeping things as clear and open channels of communication as possible.
So here are some of the things that come up for medical interpreters all the time, and we can look at the examples on this slide. For example, a lot of times people use terms which could be taken in very opposite ways, depending on if the person is saying them sarcastically or sincerely. For example, the patient might say, "Ooh, I want to vomit," or "What you just told me makes me want to vomit." And the interpreter needs to ask the patient, do you feel nauseous or do you feel disgusted? Because until I understand what he's actually meaning, I can't turn to the provider and say that accurately. Also, there is lots of hidden context. Very often people refer to something obliquely, assuming that the other person kind of can figure out what they're hinting at. But as the interpreter, we need to ask what that is, because otherwise we really won't be able to hand the other party a package of meaning. And of course we do that transparently. You know, provider, I'm asking the patient, blah, blah, blah. And sometimes the emotion that the one person is showing contradicts what the words are. And both of those things are important. So in this example, if the patient says, "Wow, I'm really, really happy that insurance isn't going to cover any of my costs," if I just turn to the provider and I say in an even tone, "I'm really happy that the insurance is not going to cover any of my costs," I am not actually helping to convey what the patient needs the provider to hear. So I'm going to clarify that probably, just to make sure that I'm not guessing. Maybe he actually means this. So as the interpreter, I'm saying, okay, tell me exactly what you mean by that. And then I go back to the provider and I can tell the provider exactly then what the patient explains.
So how do we capture everything that's being communicated? There are numerous studies that show if you attend a lecture or a training, the actual content, the words, the text, is only about 7% of what you take away from that experience. And body language and tone is a much bigger slice of that pie chart, like approaching 30%. So it's important for us to also bring that with the message. It's not just the letters in the words that paint the picture. It's also the melody of the communication. Is it off-key? Is it dissonant? Is it musical? Is it balanced? Is it angry? Is it sad? And there's a very fine line between capturing some of that tone and emotional content versus flat-out mimicry. We don't want to parrot or ape the patient's communication in a way to such an extent that would make the patient feel as if they were being made fun of. But again, that's one of the flaws of machine translation. If somebody says, "Oh, doctor, I'm in so much pain," and I just say, "Oh, doctor, I am in so much pain," that does not convey everything that the patient was saying. And nowadays, more and more, unfortunately, due to the fact that providers now need to document what's going on in the encounter during the encounter, more and more providers' backs are turned to the patients while they furiously type away and ask their questions. So it is really important to get that tone, to get that affect across to the provider. And sometimes you even have to encourage the provider with that third person voice. The interpreter would encourage the provider to look at where the patient is pointing or whatever that situation may be in order to help facilitate that communication. If he's only hearing my words, he's only getting 7% of what's going on, so we want him to look or her to look to what's going on and also help carry some of the music of what's going on in our delivery of the message.
Exactly, and what you say about not wanting to parrot or make the patient embarrassed as the interpreter when we're trying to convey what the patient just said. For example, what if the patient is fairly manic and is talking like this and is going on and on and on, and if we as the interpreter raise our voice to that extent and make it exactly as fast as the patient was doing, everybody's going to look at us very strangely because we're overdoing it. So it is a nicely balanced approach to convey the tone, but not necessarily to the same extent as the patient or as the provider. If you go to a palliative care meeting, for example, everyone in the room may be crying. The providers are crying, the nurses, the patient, the family, they're all crying. It's okay for the interpreter to cry, but it's not okay for the interpreter to bawl. Because then we take attention to ourselves, and what we need to do is just transmit it. So that's your job as a medical interpreter, is to walk that fine line.
Yes. So if your patient looks confused and your provider is typing, I would encourage you to ask the provider to take note of the furrowed brow and the confused expression to help mark it in their memory and help facilitate any additional communication that needs to take place. And it also works well if you're interpreting on the phone to ask the provider to give you those visual cues as well.
And one of my favorite scripts to use to ask the provider to check for understanding is to say, as the interpreter would like to suggest that the provider check for understanding with the patient so that we can make sure that I've done a good job of interpreting before we go further. And there again, I'm taking it on myself. It may be the provider who wasn't very clear, or it may be that the patient really doesn't have enough of a foundation to understand what happened. But I'm taking it on myself and saying, provider, I'm cueing you. Ask the patient. Doctors are supposed to know what check for understanding means. It usually means ask for a teach back from the patient to say back to the provider what the patient's understanding was of what we just talked about. And as the communication expert in the room, it is very acceptable for us to do that if we have a concern. We do not do that just for the heck of doing that. We do that when we have a concern that perhaps there is a misunderstanding or a lack of understanding.
It's always the provider's job to check for understanding because it's the provider's job to furnish the answers to any questions that come from lack of understanding. So it's our job to point out that understanding has not, the light bulb has not switched on fully, and to just point and say, perhaps we need a little bit more discussion. It is not the interpreter's job to fill in the gaps. We ask the provider to fill in the gaps and we interpret what they say.
So let's talk a little bit more about transparency. Transparent in normal English means we can see through it, like a window. There's nothing hidden on the other side. Patients often feel maybe even endangered, but certainly left out if there's a conversation between English-speaking care team members on the other side of the room, or even if the care team member is talking to the family member in English and the patient is sitting there with everybody else discussing what's going on with the patient, but he himself can't understand the conversation. That would be a lack of transparency. By the same token, care team members hate it when there are side conversations in the room. They are supposed to be managing the encounter and helping to take care of the patient and directing what happens with the patient's care. And if people are speaking in a non-English language in their presence, they feel left out, and that's very out of sync with their normal perception of what their role is being in that room. So as the interpreter, we want to be extremely cognizant of that on both sides so that nobody feels left out. Sometimes the conversation is going to happen, the side conversation is going to continue to happen, like the nurse and the doctor need to be talking in the corner about which equipment is really going to work for this particular procedure. It's not something that they would normally include the patient in English, but the patient might feel as though they're talking about the patient, making fun of the patient. So we as the interpreter will help to create transparency by explaining what is going on. And we say, the nurse and the doctor are having a conversation that they normally would not include the patient in. They're discussing what kind of equipment they're going to use that would be most helpful. Or if the care team is laughing between themselves and the patient is starting to feel that they might be laughing about the patient, we can even explain that they're laughing because one person had a flat tire today or lost his keys, or their child did something really crazy at home, and that's why they're laughing. And that resolves the feeling of being left out on both sides. So when we're in the middle of interpreting, we maintain transparency by telling both sides what we're doing, but sometimes the provider isn't actually talking to the patient, and we still provide the transparency for everybody in the room so that everybody knows what the conversation is about.
If there's more than one family member or friend present for the patient, either on the unit in their room or waiting in the waiting room or family conference, when I come in, I will often ask, does anyone in the group speak some English? And who speaks no English? I want the ones that speak no English to all cluster close to me. Because the ones that speak some English, or the spokesman for the family, or the self-appointed head of the family, or the de facto head of the family, they generally have a little bit more interaction with the world, whether they're working in the English-speaking world, and have some English and want to ask their questions. But there's usually a subset of the family that has absolutely no English or severely limited English. And those are the ones that I want to be able to have hear me, so I will ask that we all cluster together as a group to keep the ones that need the interpreter's support the most close to the interpreter. And that's just something I have found that works for me when there's more than 3 people there on the patient side.
That's a great technique, and it lets them know that you really care, that they feel included. That's great. Oh, good. Now we get to talk about positioning. Take it away.
Okay, well, I'm going to tell a story about when I went into the hospital for one of those not so critical ambulatory surgery procedures that I was supposed to be dropped off in the morning and be home in the afternoon, and instead woke up the next morning in cardiac ICU. I found it really annoying when the young hospitalist would come to speak with me that he would generally stand at the top corner of my pillow where I practically had to roll my eyes up into my forehead to try to catch a glimpse of him as he was speaking to me. And with all the drugs that were in my system, I found it made me like car sick. And if he would have just stood at the foot of the bed or at the side of the bed, it would have been so much easier to ask my questions. So I always think of that now when I go to a patient's bedside. Who's in the room? What's the condition of the patient? If they're lying flat on their back, don't make them do tennis and follow the conversation back and forth because you're on one side of the bed and the provider's on the other side of the bed. You'll make them dizzy. Try to stand with the provider in a place where it's easy for their gaze to reach you as opposed to behind the pillow, and have that little bit of consideration to think, where would I want to be looking if I were in this position? Some patients are very immobilized, whereas others are fine. They walked to that appointment today and they're sitting there next to you and moving around the room. So again, as with everything in medical interpreting, each encounter is unique unto itself. But having the consideration for where is it going to be the best positioning. And every room has a different shape, and every facility may have different rules. So you are juggling a bunch of unknowns often when you come into your next assignment. And you have to make that snap judgment of where would it be the easiest place for me to be seen by both patient and provider, and always to think of the patient first.
And often the interpreter stands because the patient and maybe a family member need to sit down. So that's fine. We don't want to waste exam room time by going out and finding a chair for the interpreter, so we're prepared to stand. When the doctor or nurse moves the patient around from the little chair next to the desk to the exam table, the interpreter will move as well because everybody else has changed his position. When we start to do a pelvic exam, we're going to move up closer to the patient's face so that we're not getting a nice full view of private parts, because that would be very embarrassing to the patient. So we preserve the person's privacy that way. Many of our patients are hard of hearing, and it's not just older patients. A large portion of the American public, of our immigrant patients as well, are hard of hearing, even if they're younger. So we want to make sure that we're alert to the fact if our patient, or sometimes even our providers, are hard of hearing, if they're looking at us very carefully, if they're turning one side of their face towards us so they can hear better with that ear, we might adjust our positioning for that. It's a fact of life that patients and providers want to be able to see the person who is speaking. That doesn't mean that we should be the center of attention, not by any means. That's why we wear business casual, generally very sober clothing, so that we're not asking for attention. But they are going to look at our face when we're talking. And then when they start talking again, we use our hands and we direct each other. We direct our parties to look at each other again as opposed to looking at us. If we're sort of centrally located so that both parties can see us, then we can do that unobtrusively. People don't have to turn around to see what we're doing. They can see us out of the corner of their eye, and that actually helps them pay attention to each other better. So we alluded to the introductions and the pre-session early on in this orientation, and we're putting it at the end of the orientation, not because it's the last thing we do, it's the first thing that we do, but because you're going to come to your own nice, tidy little pile of scripts that you use for your pre-sessions. You're going to become very comfortable with what you like to say in certain kinds of situations. Generally speaking, the first time that you meet a patient, you will do a little pre-session with the patient, which is, hello, I am your Tagalog interpreter. I am going to be interpreting everything that you and your care team say to each other. You can be assured that you will have complete privacy. Nothing that is said in your visit with your care team will leave the room. And then you do a pre-session with your provider, and Eliana did a very nice one earlier, which was very quick, clear, to the point, and it reminds the provider. So I think, do you want to do that again really quickly?
Sure. Good afternoon. I'm Eliana, your Portuguese interpreter. I'd like to remind you to speak in first person, pause frequently, and know that everything that's said will be interpreted and kept confidential. Boom. I've addressed not everything that I would like to say in the pre-session, but a couple of the things that I really want to make sure people know: to use first person, to pause frequently, to know that everything that's said will be interpreted and that we will maintain confidentiality. And then I turn around and say the same thing in Portuguese.
Mm-hmm. And sometimes you might want to ask the provider, is there anything you would like me to know about our encounter today before we begin? Sometimes you, as the interpreter, will be able to have a tiny little chat really quickly before you go into the room together. And that is when the provider could say, well, unfortunately, I have to give the patient bad news today, or this is going to be probably a difficult encounter because the patient is having a hard time using language. She had a stroke, something like that. It just helps the interpreter become oriented to how that encounter is going to go. And that is a perfectly fine thing to ask.
If you can align yourself to the purpose for the visit, what the target for today is, it does help you do a better job. If I know that it's a first visit, I know that we'll be doing medical histories and we'll be calling up childhood diseases. I know that if it's follow-up to a procedure, that there may be questions coming from the patient, and it would be nice to know what that procedure was. Or it could be preparation for a procedure. There's a lot of different things that just as you're walking in and delivering your little pre-session, it's like little drawers in my mind are opening for subsets of vocabulary that I know I want to have really close at hand. So again, when I train providers, I tell them, please, if possible, let them know, what's the point of today? Oh, today we're doing a glucometer check. Well, thank you very much. My little vocabulary drawers are opening as I find my seat, and we're ready to go.
Love that. So we're ready to give you a summary of the orientation on the nuts and bolts, the mechanics of medical interpreting, and we just want to go over these main points with you one more time.
So there is another webinar, and it is on ethics and standards of practice. So it's important to know that the ethics and cultural competence components are just as necessary as having the mechanics skills in order to have a good interpreter professional practice. So we want you to follow up these basic mechanics training with the ethics training. They're equally important. One is the left hand, one is the right hand. The summary for today, and the reason why we revisited the pre-session at the very end, is that introductions to the parties, the pre-session and positioning are very important. It helps you have a more successful interpreted encounter. And, of course, expressing the source language message in a thorough and faithful manner. Remember, everybody should be looking at the same picture, which means you exclude and omit nothing, including bad words, including opinions that you don't agree with, and you add nothing. You don't try to make the person seem more educated than they are. You don't try to smooth out inconsistencies in the story that they're telling. If they said they broke their left arm, and then when they're asked later which arm they broke, they say their right arm, you don't fix it. You say what the patient said. Use first person consistently in consecutive interpreting. Again, we've identified how to interrupt the flow and use the third person. The interpreter would like to ... so that it's very clear that this is no longer patient-provider communication. If you're speaking in the patient's voice, you are speaking in first person. And partner with the provider to achieve the provider's goals. So we know the provider has very limited time constraints. So one way to partner is to have really clear, succinct scripts for managing the encounter, whether it's your pre-session, whether it's your managing flow and interrupting the session, ways for bringing up things that happen regularly for your language pair. Think about how to explain those common misunderstandings in a very succinct, bulleted way, which is like how providers like to receive their information. Because when it's delivered that way, you come across as very professional. You've given a nugget of information to that provider that will apply to patients for this language group that they appreciate, but you did not take 5 minutes to do so, which providers hate. And always check for understanding. The completeness and the accuracy of not omitting and not adding is only enhanced when you double check for understanding, when you get that coherence of, is this what you meant when you said this? And you get that strong yes is better than any kind of guessing, well, I think they meant this. Guessing is a no-no. We want to always double check for meaning, verify comprehension, make sure that we are helping that trust bridge that is needed for patients to trust and therefore adhere to the recommendations that the providers give them for lifestyle changes, for how to take their medications, or how to prepare for upcoming events seriously and follow them to the letter. We know that this is a problem even with English-speaking patients. You start taking those meds and you don't finish those meds like you should. So having that trust established because people know what they're saying is being heard at the other end, both provider and patient, is your fundamental role. You are helping reduce health disparities. You're contributing to more positive health outcomes for patients because they're building good relationships with their providers.
And it's wonderful when we finish an encounter and everybody kind of sighs with relief and smiles about the interaction. We can leave feeling really good that they felt that they got their goals met. The patient got his goals met, the provider got his goals met, and we can leave and go on to our next encounter feeling really good that we did a professional job in the healthcare setting. We are going to switch over now to the infection control and industrial safety for medical interpreters portion of this orientation, and we're going to start out by taking 2 little pre-tests. So here's your first little pre-test. This is a question for you. You have to decide if this is true or false. Medical interpreters are not dangerous to patients if they just do these actions. If they are careful not to shake hands with the patient, and if they wear a surgical mask to every appointment when they have a cough, and if the interpreter puts on a gown and a hair cover, no matter what precautions are posted, then the interpreters are not dangerous to patients. Is that true or false? What we're asking you here is to think about, shaking hands, what kind of a mask is good to wear, should you be working when you have a cough at all, what kind of personal protective equipment do you put on for what kinds of precautions? And by the end of this orientation, I hope that you will feel very confident in knowing whether this is true or false. We'll go on to the next little pretest. Again, is this true or false? The medical interpreter should concern himself primarily with his or her own risk of infection. It is important to find out what infections your patients may have so that you can refuse assignments to interpret for really sick patients. Is that true or false? I hope by the end of this orientation that you will be able to tell us whether that is true or false. So the objectives of this part of the training are to become a fully competent and completely safe member of the healthcare team. This is a big order. What we're going to learn is how to avoid bringing germs to your patients in the healthcare setting. Avoid bringing germs from the healthcare setting into your own family and your own community. Think your child's daycare center. We want you to avoid being a vector between patients. You go to the pediatric clinic, and then you go to the cardiac clinic, and then you go to the cancer clinic. We want you to avoid getting sick yourself. One technical skill you will understand how to use is hand hygiene. We are going to teach you how to do it correctly and what kinds of personal protective equipment you are going to wear for what situations. We want you to avoid being hurt, injured, abused, irradiated, or depressed. We have two sections. We're going to talk about infection control specifically, which has to do with germs. And then we're going to talk about other industrial safety risks in the very dangerous healthcare environment. There are lots of regulating bodies which tell healthcare workers how they need to do things at work in order to stay safe themselves and in order to not hurt their patients. This includes the Department of Health in your state, which for us is Washington State. There's the Joint Commission, which regulates hospitals. There are clinic regulatory bodies which inspect clinics and see how they're doing things. There is the Federal Center for Disease Control. And every single healthcare organization has a long list of rules about what healthcare workers working there must do and must not do. As the medical interpreter living in your state, which is Washington here, living in this country, which is the United States, working in Clinic A, working in Hospital B, you are responsible for knowing what the rules are when you take a medical appointment. So we're going to be talking about these topics. Immunization and TB testing for health workers, which includes you. Food and drink regulation. Where can you eat and drink in the healthcare setting? How do you perform hand hygiene, which means cleaning your hands, correctly? It doesn't do any good to pretend you're cleaning your hands. That doesn't save lives. We're going to teach you how to do it right. There are special precautions that you have to be alert to. You have to see that there are special precautions posted in the first place. So we're going to plant little red flags in your brain. There are all kinds of special rules for when you enter particular parts of the healthcare setting, for example, the surgical areas or the labor and delivery areas or the neonatal intensive care area. Certain kinds of procedures that involve sharp objects or which involve body fluids have many more rules around them, and we want you to be alert to those. And because medical interpreters work with people, we work with patients, family members, members of the public at large who are not even our patients, but they're right there next to us in the elevator, and we work with all of those other healthcare workers. There are going to be interpersonal dangers at times, and as a medical interpreter, we want you to know how to handle those safely. When the medical interpreter walks into a room, the patient looks at the interpreter, the provider looks at the interpreter, and everybody assumes that the medical interpreter is a fully trained healthcare worker, that he knows all the rules, that he has been trained in safety, and that he's not going to do anything inappropriate or unsafe. Unfortunately, until very recently, we have not had special training for medical interpreters to bring them all of the knowledge that other healthcare workers have. When an interpreter takes even one assignment a year in a healthcare setting, he is a healthcare worker, and he is responsible for making sure that he is a fully safe and competent healthcare worker for that one assignment. So take this information, practice it, ask questions about it, and please, please share this information with all other medical interpreters that you know so that we can all be safer for our patients and for our own communities. We're going to start with some infection control principles. We're going to go over the topic of what is a vector, what is a reservoir of infection, what is an incubation period. We're going to talk about how important immunization is. Why is it so important? We're going to talk about precautions, universal precautions and extended precautions. We're going to talk about specifically vulnerable populations. We're going to mention sterile procedure areas and how you as the interpreter should be prepared for maybe going into one of those areas by how you get dressed that morning, what you take with you as you go to that assignment. And there are some proactive behaviors that you can carry out as an interpreter in the healthcare setting if that is permitted in the facility that you're working in at that particular moment. Let's begin with the concept of vector. A vector in mathematics means an arrow. It starts at one point and then there's a line, and at the end of the line there is the arrowhead. So the concept is that something goes from the base of the arrow to the point of the arrow. Something moves from one place to another place. There is a change in status. It goes from here to there. This is a very effective way of thinking about how germs work. So when we talk about infection, we talk about a vector as being a carrier, a means of transmitting a germ from one place to the next place. A germ can be carried by mechanical means or by biological means. And I'll give you an example. Let's say I am the interpreter, and I sit on the bus on my way into work, and the person next to me coughs on my jacket. And I have all kinds of droplets and germs on my jacket. I get to my assignment. I take my jacket off because it's really hot in the exam room. I drape it over the back of my chair, and the patient's little boy walks up and puts his fingers in his mouth and holds onto my jacket because it's a nice, snuggly jacket, and gets these droplets all over his hands and probably in his mouth too, but then he sits on mommy's lap, and the droplets are now all over mommy. That is a mechanical vector. The droplets have gone to my jacket and then onto the child's hands and then onto mommy. So it has moved on surfaces. We as interpreters come from our families and our communities, from whatever we were doing. We go to our assignment, and everything that's on us, our clothing, our hair, our handbag, our attaché case, our shoes, our phone, our pager, everything that's with us is in contact with whatever in the environment, to whatever extent we let our environment get germs on us. And then wherever we move through the day, we're adding to what was on us at the beginning, and we're carrying it from place to place to place as a mechanical vector. So we need to be super cognizant of that function that we're providing. We don't want to do that, but we're doing that every day. There is a different kind of way of being a vector, and that is if we actually get infected ourselves. So now I'm on that bus, and the person next to me coughs, and I breathe that air into my own lungs, and after 2 weeks or so, I start coming down with the sickness. And then I realized that yesterday I was kind of not feeling very well either, and I had 10 different appointments in 10 different clinics, and every time I coughed yesterday, I was sharing my germs, because now they're my germs, with whoever was in my environment. And if they breathed in my germs, then I have been a biological vector for them. I have taken it into my body, and I've gotten infected, and I've gotten sick, and I've carried it to other people like that. So those are two different ways that we as interpreters can be vectors. We all have lots of germs on us all the time. A large portion of our physical bodies are actually not human cells. They're different kinds of bacteria and viruses that live very harmoniously together. It makes up our biome. It's important to our health to have them. And most of the time, we are just perfectly healthy and happy, and that's great. But at some time, a germ can get out of boundaries. It can start to proliferate, and it can take over the normal balance. So for example, I might have MRSA on my skin today and have what we call a colonization of MRSA. It's a normal part of my body. It doesn't make me sick because it's on the outside of my skin and my skin is intact, so it's not making me sick, but I am colonized with it. So if I go to a patient who's immunosuppressed and has no ability to fight off MRSA, and I just wipe my MRSA-covered skin on his bedclothes, and then he gets that into his surgical wound and he's immunosuppressed, then it could make him sick. He would be infected. I am only colonized, even though it's the same germs. So we need to think about the fact that just because we don't feel sick doesn't mean that we aren't colonized with a variety of germs that could be harmful to our patients. That's why we pay so much attention to covering ourselves up in certain cases when we go to vulnerable patients, and we pay so much attention to hand hygiene because what's on our hands and not make us sick could make somebody else very, very sick.
So here are two practical tips for how to lessen the impact of being a mechanical vector. Talk about that first. So when you're interpreting, particularly if you're interpreting as an independent contractor and you're going to a variety of locations, I would strongly encourage the ladies to stop carrying the great big shoulder bag. Leave that locked in the trunk of your car. Get a jacket or a vest with multiple pockets. Use a fanny pack or a belly bag to carry those critical things that all interpreters need, whether it's breath mints, chapstick, Kleenex, a pen, your cell phone or your pager, a small pad to write or take notes on. All of those things should be like your emergency interpreter kit and should fit into something small enough that it stays on your body and you have no need to put it down on any surface, whether it's a cafeteria table, exam room table, or, God forbid, the floor of a variety of different locations where you're interpreting. My purse, which I do not carry to individual interpreting assignments, still, when I get home, that very first closet near the front door is where I hang my purse and where I slip out of my shoes so that I don't track in all the germs that I walked through that day into the rest of my house. I don't want to bring stuff home to my family, and I also don't want to pick up stuff while I'm in a variety of medical settings. That's the mechanical. And then for the infectious organism, this is the part that directly impacts on the interpreter's decision to get their flu vaccine, to get their immunizations regularly updated. We recently, in the last few years, have seen a real spike in the number of infants dying from whooping cough. because they have to be a certain age before they get that pertussis vaccination. So they are vulnerable in those first few months. And we could unwittingly be colonized, show no sign of infection. Remember, we are rubbing elbows with every type of sickness and infection that there is if we're working at a medical center or in an emergency department. And so then again, just because somebody comes into contact with our sweater or some part of us that could be carrying something, we don't want to add to anyone's burden and inadvertently infect a sweet little baby or anybody else in the family. So there are two things. We have to be watchful of where we're stepping, where we're rubbing, where our jacket has been, where our knapsack has been, our backpack, our courier bag, whatever it is that you carry your stuff in. Be mindful of where you're putting it. Try not to carry large items with you that then end up on the floor or in contact with a variety of surfaces in the hospital. And be careful where you put them when you come home. And be up to date on all your immunizations and flu vaccines so that you don't carry as a colonized person and that you don't carry mechanically by dragging germs that you picked up on the surface of some items of clothing or accessories that you bring from room to room. So find something that works for you that is not an extra bag that you have to worry about leaving behind, but that you still have the tools that you need to get through your day.
I love your idea of a vest with pockets in it. That's really beautiful. You can put your keys in there too. A couple more concepts that we're going to talk about. Ileana just mentioned, why do we get vaccinated? Because an unvaccinated person can be a reservoir of infection that can infect the entire community afterwards, especially because there is an incubation period between when we take in a germ and the time that our body is making lots and lots and lots of new baby germs and when we actually feel sick enough to know that we're sick. So there's a period of time, the incubation period, when for many diseases we are infectious, but we don't know that we're really sick yet. That's especially true of the flu, for example. So we are infectious with the flu before we have symptoms. That's different from Ebola virus. In Ebola virus, you're not infectious until you have symptoms and you know you're sick. But Ebola is different from most of our diseases, where you can definitely be sick. And you function, therefore, as a reservoir of infection that can reach back out into the community and infect people. There is a vaccine effectiveness time lapse, so we need to tell you that when the flu vaccine, for example, comes out every October, comes out right at the beginning of October, we want every medical interpreter to get that vaccine the first week that it's available. Why is that? Because sometimes people wait until January when the CDC comes out and says, oh my gosh, we're having a huge resurgence of the flu. We're seeing lots of people die in the hospitals from flu. We want health workers to go out and get the flu vaccine if they haven't had it yet. Of course, as interpreters, we are health workers. If we wait until January when there's a resurgence and then we get it on January 1, it's not until January 15th that we're actually prepared to fight off the flu when we get it. There's a 2-week period when the flu vaccine cannot help us yet. So what we want to do is, when we're healthy, we get the vaccine as soon as it comes out, and then we're protected for the rest of the season. These are the immunizations that every interpreter needs to have. This is the list put out by the Center for Disease Control. This is for the entire country. Nobody is excepted. Biology always works the same for everybody. These are critical immunizations for every health worker. If we take one health assignment, we get these immunizations. And
the only exception would be the person who's old enough, like I am, to have actually had chickenpox, measles, mumps, and rubella in my childhood. So now I'm vaccinated, so to speak.
And what we do is
anyone younger needs to get the vaccination.
Right. And the way we know that somebody is safe and has been is now protected against these diseases is that we do an assay. So in the hospital, for staff, what they do is they take a blood sample and they look to see if you have immunity against all of these diseases. And whatever you're missing, then they give you those pieces. So for the medical interpreter working through an agency, what you need to do is talk to your doctor, take them this list, say, I'm a health worker, I take medical appointments, I need to know that I am safe against all of these things, and your doctor will help make sure that you have the immunizations you need, you have your annual flu vaccine. We recommend that you have hepatitis B immunization because if someone pokes you with a needle, you're more likely to die from getting hepatitis B from that needle than you are from getting HIV from that needle. Health workers get poked a lot. We never see it coming, and all of a sudden you're poked and you've got hepatitis B, which is life-threatening. And you need to have your TB monitoring done annually. And again, we don't have that available through public health anymore. You need to get that done through your own doctor's office. You need to be able to have this jacket of protections documented so that if anybody asks you for these, you have it all ready to go. We know you're covered. I'm going to mention just one thing about TB, and that is that a lot of our immigrant interpreters who were born in other countries, or like myself, who grew up in other countries, received the BCG vaccine. So there are two different ways of trying to keep tuberculosis out of the population, one of which is an immune-based method, and one of which is just a checking and monitoring method. So I'll tell you the difference, because we always get a lot of questions about this from our interpreters when they talk to them about infection control. If you have had the BCG, that is actually an immunization. It is supposed to prepare your body to recognize tuberculosis when it sees it and be able to fight it, so that then you can be in a place where there is TB in the population, but you're going to be safe because your body fights it off every time it comes in contact with it. The problem is that now we know that BCG can wear off, just like we're just finding out that the whooping cough vaccine that all of us had as children can wear off. I got whooping cough in year 2000 at Harborview from another health worker who got it from a patient, and we had all been vaccinated. So I was part of the new epidemic of whooping cough. We know that people who have received the BCG vaccine in their country of origin can have their immunity to tuberculosis now worn off. So we're switching all healthcare workers, including medical interpreters, over to the American way of making sure that people are safe from TB, which is a monitoring mechanism. We're not giving people an immunization. What we're doing is we're checking each year to see if they have a reaction to a TB skin test, which tells us that they have been exposed to tuberculosis recently and are trying to fight off their exposure. If we see somebody have a big red reaction on their skin when we give them the skin test, we know that they have been exposed to tuberculosis recently, and we start doing symptom checks for them periodically. So we ask them, do you have night sweats? Do you have coughing? Do you have weakness? And if the answers to those questions become positive, then we do a chest x-ray and probably give them medication against tuberculosis and watch them very carefully from there on out. I hope that's helpful for your questions around BCG. There are two reasons to not accept an assignment if you are an interpreter having to do with infections. First of all, to keep you safe. If you are pregnant or if you are immune suppressed yourself and you are an interpreter, there are some kinds of visits that you probably will just automatically refuse to take. For example, pediatric clinic appointments, because there are so many communicable diseases present in pediatric waiting rooms. Pretty much any place you go in a pediatric clinic, there are just germs everywhere. So if you're pregnant and vulnerable, for example, if your doctor advises you to not be in crowded situations, then you would not want to take that kind of appointment. Many interpreters take medications to, for example, for rheumatoid arthritis or for cancer, which decrease their immune response. You should not be taking care of pediatric patients. You should be taking assignments in areas where people do not have infectious disease. And there are very strong reasons to refuse to take assignments for the safety of the patient. We can kill patients if we do not observe these rules. When you are not feeling well, especially if you have respiratory symptoms of any kind, if you have severe diarrhea, if you have open skin lesions that are infected with something, you should not be accepting assignments to see patients of any kind, because we can't tell which patients are vulnerable just by looking at them. We need to stay home.
You can still interpret remotely.
Yes, pick up the phone. That's a great way to interpret when you're not feeling well. Absolutely. Here's a really important term for us to know, and it's health-associated infections. Doesn't sound like much, but this means that we as health workers actually make our patients sick. Sometimes we kill our patients. This is a huge problem in the United States. It's a huge problem in every country, but we live here, so we need to pay attention to how serious this problem is here. A health-associated infection is an infection the patient did not have before he came to see us. He was safe before he came to see us, and then we let him get sick. That's pretty horrible. We're supposed to help take care of our patients, and here we are making them very sick or even killing them. The CDC says that every year in the United States, an estimated 2 million patients get a hospital-related infection. They weren't sick before they came to us. Those 2 million people got sick because they came to us. And 90,000 of those patients die from their infection. Many infections are transmitted on the hands of healthcare personnel. We need to really take responsibility for this. There isn't any way right now where we can track those germs back to the person that it came in the door on. Maybe down the road in the future, they'll be able to track that back to a specific person. It might be the doctor or the nurse or the interpreter. We don't want to be the one that brought the infection to any patient, ever. Just to note that every institution has its own rules. In some hospitals, you may never go into the room of a critically ill patient because they would use telephonic or video interpreting for that patient instead of trying to help the interpreter get all gowned up and masked and so on. But in many other hospitals, you will need to be very aware of the rules, and you will be expected to go into the critical care areas. So we want you to be prepared to do it either way, to do the full garb if that's what's required of you. These are the most critical patient areas where you need to be on high alert. Sometimes you're given an assignment, happens all the time. You're supposed to go to the otolaryngology clinic, and you get there and you find out that your patient has actually been admitted to the ICU last night, and would you please go up there because the doctors on ICU need an interpreter. So you didn't come into work thinking you were going to be on the ICU, but you're on the ICU now. And you should immediately change the way you think about infection control at that moment. You go from low gear into high gear. So the neonatal intensive care unit, extremely vulnerable patients. They have a lot of tubes going in and out of their bodies. They do not have a mature immune profile yet, and often they're very sick as well. So they're extremely vulnerable. we basically don't take anything onto the NICU. We don't even go onto the unit unless we're absolutely needed on the unit. That may be another unit where they keep interpreters off and just prefer to use a telephone just to keep the number of people on the unit down. The intensive care units for adults are that way. People have a lot of ports in their bodies or wounds in their bodies, so they're more susceptible to infection. Certainly the cancer units and floors, the transplant floors, because to get a transplant you have to be immune suppressed so that you don't reject your organ. HIV and AIDS patients are immune suppressed because the disease itself kills off their mechanism for protecting them. And many patients are on steroids, which also give them immune suppression. As Eliana said, take nothing into the room that you can't put underneath your gown. Do not take your coat into an exam room or into an inpatient room. Leave it out in the waiting room, leave it somewhere else, leave it in your car. You will gel in. No matter where you go in the hospital, even if you're going to put gloves on, you gel in first. Don't touch anything in the room. Don't rest your arm on the rolly cart. You think, well, the patient's dinner is going to be on that rolly cart. I bet it's really clean. Well, actually, think about where that patient's hands have been in bed all day. Where have that patient's hands been? I wonder where that patient's hands have been. And then guess what? When he reached for his dinner, his hands were all over the cart that you just leaned against or put your phone down on. Do not shake hands. Do not touch the baby. A lot of our cultures are firmly based. We enter the room, we immediately shake hands, or we put our arms around each other, we kiss each other on the cheek, we clap each other on the shoulders. We cannot do that as medical interpreters. Healthcare workers in general are being told that's not part of a good practice anymore. Yes, it establishes good friendship, good relationship. We can do that with words and a smile. Do not shake hands, even with the patient's family, because guess what? The patient's family has had their hands all over the patient, and you know where the patient's hands have been. One really important note that came to us from the Seattle AIDS Foundation, which is a colloquium of many organizations that help to take care of the needs of HIV and AIDS patients in the Seattle area, was that they have had a really hard time getting medical interpreters to come to help them take care of their patients. And many interpreters refuse, saying quite clearly, I do not want to take care of HIV patients. This is where we're going to do some really tough talk. If an interpreter is going to take any healthcare assignments, then he is a healthcare worker. And if he is a healthcare worker, he needs to take care of patients. He doesn't cherry pick the patients who have nice diseases. He needs to take care of patients who have any disease that they have. It's not their fault that they have what they have. We all have things that we would probably not want made public. And we need to, as healthcare workers, treat everyone with respect and dignity and be prepared to give our best service to everyone.
This goes back to what we talked about earlier, when to recuse yourself from a situation. And it has to be only because your level of competency is not adequate to the task, not because of any feelings, beliefs, traditions, or choices or judgments that you make. The only judgment is, am I up to the task? Do I not have the vocabulary necessary to discuss chemotherapy? Then I am not the best interpreter match for this encounter. That's really the only reason that you should back out. Or if you're sick and you're afraid of contaminating somebody, then you should be working remotely. But again, it's patient safety. It's not interpreter preference.
Right. I mean, what would have happened if Florence Nightingale had said, oh, let's see, I'll go to Turkey, I'll take care of all those wounded soldiers, but the ones who are dying of cholera, I'm not going to get my hands dirty with those guys. She set a really great standard for all of us, and we're proud to continue in her footsteps. So how do we do this? How do we do this right? We want to do hand hygiene right. Okay, basic rule for healthcare workers, and that includes you, is gel in and gel out every patient, every time. Do it correctly. Don't do it haphazardly. Don't forget. If you forget and you realize that you've been with the patient for 10 minutes, guess what? Go do it now. You can even do it when you first come into the hospital, and when you have finished all of your appointments and you walk to the other end of the building and you're about to leave the building and get in your car, you can gel out again. Gelling in and gelling out is key to this whole thing. So what are we talking about gel? Gel is alcohol-based, emollient-containing fluid which kills germs really, really well, much better than soap and water, and it has protections for your skin. So the way we used to take care of keeping our hands clean was soap and water for 3 minutes, or 30 seconds if you weren't in a highly surgical area. And what we were doing was we were actually damaging our skin by doing this washing. So the Centers for Disease Control have mandated that gel is very much preferable to soap, and I'll tell you why. If you use soap and water more than a few times a day, the way you get your hands clean with soap and water is to push hard. You're actually breaking down the top layers of the skin on your hands, which makes them more susceptible to have germs sitting on your hands. You're actually making it easier for germs to colonize your hands because you're destroying the protective outer layers of your hands by too much soap and water. So don't do too much soap and water. Get used to gel. Make it your friend. It will save lives. It's also required. So gel in. That means you walk onto the unit, could be the waiting room. Put gel on your hands. You're going to be sitting next to the patient, maybe helping him fill out forms. So when you pass that pen back and forth, who knows what you're passing back and forth? Your hands start out clean. Or if you go directly to the exam room, before you position yourself, while you're doing your pre-session, you can be gelling your hands. So I'm going to teach you how to do this right. The worst place for germs on your hands is around your nails. So our method from the CDC is to first take care of the nails. So I want you to close your eyes and hold out your left hand, cup your hand facing upward. You're going to take your bottle of gel and give 2 squirts into your left palm. So now you've got a puddle in your left palm. Take your right fingers and your right thumb and put them all together, all your fingertips together, and now dip them in that puddle really, really well. Kind of rotate your fingertips around in that puddle really, really well. And you've just killed 90% of the germs on your fingertips, which is where they're really hard to get at any other way. Now open your right palm and hold it upwards and wipe your puddle from your left hand onto your right hand. Now you've got a puddle in your right hand. Take your left fingertips, stick them in the puddle, roll them around. Now your left hand is 90% done. Now wipe your palms together, but you're not done. You need to do the backs of your hands between the backs of your fingers and hold each thumb and go completely around each thumb, because those are the areas that normally get left out. I'm going to go backwards here and show you a room in a hospital that we thought was clean. This had been completely cleaned with all of our new methods of cleaning things. And when the infection control checkup team went around and they took samples from these surfaces where there are little green X's and put them on a Petri dish with a nice nutrient solution and put them in the incubator, really nasty germs grew out from the swabs from all of the places where you see green crosses on this slide. So think of you're the interpreter and you're coming to visit this patient and they're bringing this patient up from ER. You know, this is a clean bed. They're putting your patient in a nice clean bed and you think, oh, nice clean room. I guess I can put my big fat purse down on the sink over there. I'm staying out of the nurse's way and obviously it looks nice and shiny, so that's perfectly cool. And then I'm going to the patient is asking to have something given to her from the set of drawers over on the left-hand side because she has her bag of belongings over there and she asks you to move it for her onto the bed. So you go over there because you're a nice little person and you pick up the bag and you put it on her bed. But look, there was a green cross on that. So what used to be on that surface is now on the bottom of the bag that you just handed the patient, which she just put down on her sheets. And guess what? It's on your hands too. So we want you to be really impressed with the fact that just because it looks clean, it isn't clean, and it's up to you to make sure that you gel in and gel out enough times between patients that you are doing the maximum you possibly can to break the cycle of infection. This is where we normally forget to cover the orange parts and the fingertips, which should be blue, is where we forget to do. Now, our wonderful interpreters love to get dressed up and look professional, but long nails are not allowed, and fake nails are absolutely banned now by the CDC. That is pretty new information, and I know it's really hard for a lot of women and even some men to make sure that their nails are short. Please do that as a way of making sure that your patients are safe. So find points of soap and water when you actually do have to wash your hands, which is after you use the bathroom, before you eat, or if you get something really yucky on your hands. For example, if a patient throws up on you and you get vomit on your hands, that's when you want to do the soap and water thing. So you're going to do soap and water, and you're going to gently massage each part of your hands, not forgetting any of those places that we usually miss, and then you're going to dry them properly. And
very important, I think, to remember to use the most recent paper towel as you get drier and drier. That last one is semi-dry. That's the one you use to turn off the faucet. And the one that I use to pull the door open to exit, then I do a half turn and ball the paper and toss it into the container and walk out, so that my now clean hands don't have to touch the door handle, which is probably really filthy if we were able to capture all the living organisms that are residing there.
Yep, lots of little green X's on those door handles. Very good. Okay, we're going to switch gears here a little bit and talk about some more concepts. Back when I started doing healthcare, which was many years ago, quite a few decades ago, we thought we knew which patients had dangerous diseases, and out of our whole practice of patients, we would say, okay, Mrs. So-and-so is coming in next Wednesday, and she has a dangerous disease, so for her, we're going to put gowns on. We're going to make sure that we put double layers of table paper down and take extra special care to protect ourselves from what those patients had. It could be tuberculosis. It could have been hepatitis B, for example. But when we had the HIV/AIDS epidemic come forward and we realized that a person can have really dangerous diseases like hepatitis B or HIV for 10 years before he shows any symptoms at all, we started to realize that we needed to completely change and upend our way of protecting ourselves. So we went from pretty much no precautions around anybody except for a very few patients to universal precautions, which is we imagine that every single patient that we're going to see has a disease that can kill us. And we are going to take full precautions as though every single patient has a disease that can kill us. That is universal precautions. So if I have 100 patients today, I am going to do the same precautions for every single patient. Mostly that has to do with blood-borne diseases. Basically, it's about body fluids. Body fluids must not get on me or into me under my skin, and that will keep me safe. So I am going to pay particular attention to any time I cut a patient, anytime I deal with a patient's blood, urine, saliva, semen. I don't want any body fluids getting into my blood, so I want, if I have an open sore, I have that covered with a bandage when I go to work. I do not want to get blood splashed in my eyes. I do not want to inhale any blood because I'm leaning over a wound and all of a sudden the wound explodes and I get that into my mouth, onto my mucous membranes. So we now look at every patient as being potentially lethal to us, and we take precautions against body fluids from our patients. In addition to the universal precautions, we now also add on to that special precautions when we're working with patients with known diseases. So I make sure with all my patients that I'm doing universal precautions against body fluids, but in addition to that, if I know my patient has tuberculosis, I take extended precautions specifically against tuberculosis with that patient. If I have a patient with C. diff, which is an infection of the colon with a very dangerous germ, I am going to take specific extended precautions when I work with that particular patient, on top of also making sure that I take universal precautions when I'm working with that patient. Think body fluids. Now, you think, well, I'm a medical interpreter. Why should I have to worry about this? Let's talk about that for a second. Every time you're with a patient who has an IV put into place, every time you're with a patient who is getting an injection of any kind that pierces the skin, somebody who has a port being placed, somebody who has had a surgery and now has a surgical wound, anybody who has a boil that is being lanced, anybody who's throwing up, that's a body fluid. Sometimes we get pee on us, sometimes we get poop on us. Not a lot, but sometimes. Those are body fluids. And we think, well, as the medical interpreter, I'm standing on the other side of the room, so how could I possibly get these things on me? Well, what happens is that sometimes the patient jerks, or somebody falls down, or a vial of blood slides off the counter and breaks on the floor, and you have, I hope you don't have, but let's say you do have open-toed shoes on, and that piece of glass infected with blood pokes your skin, you could actually die from that. So we want to bring you into a state of heightened alertness to the dangerousness of the environment that you work in. So we have lots of ways to keep everybody safe. We've talked about hand hygiene. There are special, cleanings of the rooms that happen, including ultraviolet cleaning of the surgical rooms. We put patients in isolation so that there's minimal contact with people. We try to keep non-essential supplies out of rooms with infected patients. We have negative pressure rooms for people with respiratory patients' diseases so that the air is sucked up into a special container and it's decontaminated before it comes back into the hospital. We have lots of protective equipment like gowns. We have disinfection of our hands, rooms, and equipment. But what you can do in addition as a medical interpreter is really what Eliana talked about earlier, which is going the extra distance to not bring any of your stuff into the environment if you can help it, keeping what you bring in very small so that it can go in your pockets or in a fanny pack and under a gown. That's the main thing, so that you don't have anything exposed to the environment if you're asked to see a patient in isolation. So we're just going to run through what you need to keep your eyes out for. I've noticed that in our hospital, we used to have these wonderful precaution signs right in the middle of the doors in the emergency department and in the inpatient area. So when you go to the door and you open it, you're looking at the sign right in front of your face and you're more likely to notice it. However, in our hospital, in some units, we have now moved these signs over to the side of the door where there are other things posted and there are, you know, there's the bottle of hand gel and all kinds of other stuff. It's very easy to miss the fact that there is a precaution posted that is other than just universal precautions.
That's why I think it's really helpful that you've listed or posted images throughout this presentation of all the different ways these precaution notifications can look when they're posted. You need to run through this section and become really familiar with this information, how it's laid out, all the different examples that are featured, so that your eyes will recognize, oh, there's one of those precautions, and it'll stick out from the cluster of other information that may be surrounding it. You have to take note of these, so you need to know what they look like. And that's why I'm really grateful, Linda, you collected all of these and have them featured as we go through, because this is your danger sign.
Absolutely, absolutely.
And you need to pay attention to it, and you need to request the personal protective equipment if it's not immediately offered to you. And it's not because providers don't think you're important. There may be some urgency going on with the patient. And the minute you remind somebody, hey, where's my personal protective equipment, somebody's going to run out of the room and help you get into it.
Absolutely. Absolutely. It's kind of like when you're flying a small plane and you know that you're in volcano country and you've heard the rumor that there might be some active volcanoes in this country. You're going to keep a pretty sharp eye out. Well, this is what we want you to keep a really sharp eye out for as a medical interpreter. Remember, these notices can be in the emergency department. Somebody comes in, has certain symptoms, the first thing they're going to do before they're even sure that they've got a specific infectious disease is they're going to slap this on there so that everyone going in and out of that room doesn't have to be traced down later and checked for the next 6 months and may be sick enough to die because we didn't recognize it early enough. Like that man who in Texas had come from Africa and he had the Ebola virus and he was sent home from the emergency department and he eventually died. We don't want to be part of that scenario. We all want to be really, really aware and alert of infectious threats. So what you see on your screen right now is the standard precaution notice. This means assume that this patient has bloodborne diseases that can kill you. Watch out for sharps, like for every other patient. You don't have to wear a gown unless you're going to be physically handling the patient. You do need to gel in, you do need to gel out. So this is your basic universal precautions notice, and this is what's going to be on the door if there are not additional precautions. So let's look at some of the additional precaution posters. The color can be different from place to place. What you need to focus in on is the top of this. It says airborne respirator precautions. That's not universal precautions. That's specific airborne respirator precautions. And then underneath there are the pictures that really alert you to what you need to do. You can scan this. Our brain works much better with pictures than it does with words. So at the top, you see the little hand gel bottle with the hand. Okay, we know that's universal precautions. We were going to do that anyway, right? But underneath in that pink section, wear an N95 mask and eye protection, or a PAPR, which is the motorized hood that just feeds you clean air. If you walk in without this protection, you could get an extremely, extremely fatal respiratory disease. You want to train your eye to look for this. You also see in the lower right-hand corner a door. That means this patient is in a negative pressure room. This door has to stay closed, guys, because we want the air that's around the patient to get sucked up into a special system and not come out into the corridor. So when you go into a room like this, after you're fully covered with your protective equipment, you go in that door and you close it right behind you really quickly. You don't leave it open. And if you see the patient's family kind of taking its time, walking in, you say, you know what, this door needs to be closed. Come on in or out. Everybody's responsibility at that point. Or bring it to the attention of the nurse if you have any concern at all about overstepping your boundaries. We don't want you to overstep your boundaries. Whoops. Okay, on the bottom of each notice, you will have additional information that helps you understand what's going on. I'm not going to go over each one. I'm just going to go through these and show you that there are different ones. This one is airborne contact precautions. Contact is always your clue that surfaces in that room are covered with really bad germs. Anytime it says contact, the surfaces are extremely dangerous. The one we saw before, airborne respirator, does not say contact. What you're worried about here is breathing the air. What you're worried about here is breathing the air and the surfaces. And again, you have the pictures that show you what to do. Droplet precautions. And it reminds you, in addition to standard precautions or universal precautions, it tells you what to do. Contact precautions. Every surface is awful, really bad. You can see at the bottom, healthcare providers and staff use patient-dedicated equipment, clean and disinfect equipment that came out into that room. That's why you want your mobile phone inside your fanny pack underneath your gown. You do not have that phone out in the air in this room because you will have to completely decontaminate it before you take it out of the room. You don't want to have to do that. Kind of wrecks your phone.
And you need to remove your protective equipment when the contact precaution is up inside the room and dispose it generally. There's some holder of used gowns and masks and gloves.
And we go over that in a minute, too, a little bit. But yes, you're absolutely right. So you always put on your equipment before you go into the room. But you take off the equipment inside the room before you come back out with whatever those germs were. You don't bring that back out with you. So here again, this one is contact enteric precautions. Enteric refers to the intestine. That means that you have germs from the patient's infected intestine all over the room, on every surface. Think about the doorknob going out of the patient's room. It's probably infected too. So when you come out of that room, you make sure you gel out outside the room. So it's just think of everything as being covered with lots of stuff. This is a particular type of germ where it tells you to wash your hands with soap and water. You see it doesn't have a bottle of gel at the top. It has hands washing with soap. And that is because gel doesn't kill this particular kind of germ. So you wash with soap and water before you leave the room, but it's not because soap kills this germ either, because it does not kill it. What it does is the mechanical action of washing for 3 minutes pushes the germs off your hands and goes down the sink. So you need to do it really thoroughly. So let's look at the personal protective equipment. You have the lady wearing a plastic eye cover so that if there's blood splashing, she doesn't get that in her eyes. She's wearing a mask. For interpreters, wearing any kind of a mask poses a huge challenge for us because we're there for communication. So if we're wearing a mask, the providers and other staff are also wearing a mask, so we can't see their face when they're talking. We can't understand them as well. If they have an accent on top of it, or if they're muttering or mumbling, it's very hard for us to know what even the provider team is saying, so we need to ask for clarification. And nobody can see our mouth either. So if we have a hard of hearing patient, we need to slow down as we speak, make sure that people can understand what we are saying. Otherwise, there's no point in our being there at all. The gown is tied in back. The person has gloves on. When you wear gloves, you still gel in and gel out. And we have a little reference for you here on how to remove your personal protective equipment. Basically, you always peel it from the back towards the front. So the front of you is contaminated more than the back of you. Another reason we don't back up and lean on things, because then the back of us is contaminated too, and it should never be contaminated. Don't rest against the rolly cart. Don't rest against the wall or the sink. Stand in the middle of the floor. And then untie things and roll them towards the front with the inside out and put them in the containers designated for them, which are usually in the room. And it's a very good idea to ask the nurses or whichever staff are in the room to remind you how to take off your personal protective equipment. So the difference between two different kinds of masks is very important for the interpreter to understand. Most of the surgical masks that we see people wearing in the hospital are just a barrier. They just prevent the spit from the surgeon from going into the patient's cavity when the surgeon is bending over to do surgery. It's just a barrier. It doesn't kill infections. It just prevents spit from going back and forth. So, or it prevents the patient's body fluids from hitting us in the face and then dribbling into our mouth. It's a barrier. But for respiratory diseases like tuberculosis, there's a special kind of mask. It's called an N95 because it will prevent about 95% of the really bad germs from getting to you. We won't even think about that other 5% that it didn't prevent from getting to you. But anyway, if you're staff interpreters, you will be using the N95s because you'll be fit tested for it and you'll have a specific size assigned to you. But if you're an agency interpreter, you will be wearing the other mask shown here, which is the one with a little motor that is on your back. And it feeds you clean air into your mask, and then you just breathe out, and the air you breathe out comes out by your chin and out back into the room. But every time you breathe in, you're breathing in clean air that's gone through a very, very good filter. And that's called a PAPR. The nurse will help you put that on. Want to let you know that all over the country, there are more strict rules now about what can go into surgical areas. So we used to have interventional radiology areas where people could bring their backpacks. The staff in those areas would bring their backpacks and put them around the edges of the room. People could wear their own jogging suits underneath their blue jumpsuits, for example. But now it has become incorrect to wear anything that sticks out from under the suit. So the jumpsuit that you put on has to completely cover your skin. None of your clothes can stick out at the arms or the legs. You can't have any jewelry showing. You have to wear a hair cover. All of your belongings have to be underneath your gown. And I recommend that women interpreters who have any possibility of being assigned to a surgical area not wear a dress that day, because it's very hard to wear a jumpsuit with a dress on underneath. It gets really kind of wadded up and bulky around your waist. So I recommend wearing pants when you do interpreter assignments. Here are two of our staff getting ready to go into the C-section area. The lady on the right has the jumpsuit on. The lady on the left has, it looks like she has black pants on, but those are actually furnished by the hospital, and she's completely covered up. They've taken all their jewelry off. Here's another of our staff in full lead in interventional radiology, and that is over her jumpsuit. So here's a little post-test for you to see if this made any sense. So let's ask you that question again. A medical interpreter is not dangerous to patients if he just does these actions. Does not shake hands with patients, wears a surgical mask to appointments when the interpreter has a cough, and puts on a gown and a hair cover no matter what precautions are posted. So are those three things sufficient to protect patients in all cases if that's what the interpreter does? True or false? And I'm going to tell you the answer. The medical interpreter who only does these things is very dangerous to the patients. So go back and study if you thought that was enough, because it's not. Here's the second post-test. The medical interpreter should concern himself primarily with his or her own risk of infection. Well, I would say Eliana gave a very good explanation of the fact that this would be false. We take care of any patient. We don't ask about what infections they have so that we can say yes or no, I'll take care of that patient. Summary of infection control. The healthcare environment is highly dangerous. Medical interpreters, just like all healthcare staff, are potentially deadly vectors of infection to and between patients. I would say that we are the most dangerous vectors in healthcare because we're the ones who go from clinic to inpatient to intensive care unit, and then we get in our car and we go to a different hospital and start all over again. We could go to 20 different places and take germs between 20 different places, which no one else in healthcare does, just the interpreter. And the main takeaway is that we as medical interpreters must practice all of the same infection control behaviors as other healthcare workers. We're going to go very quickly through the concepts of industrial safety. Again, it's a very dangerous environment, and not just because of infections. We're going to look at some of the other areas of safety or danger in the healthcare environment. For example, radiation safety, mechanical safety, which means getting banged into or getting hit or pinched. Chemical safety, what kind of chemicals could get on you, could you breathe in? Cold, heat, weight, the need to stand up for long periods of time. Physical danger from other people in the environment, inappropriate behavior from people like sexual advances, people being very cruelly abusive verbally to the interpreter. What happens if there's a disaster while you're on the job? And how about our mental health? The fact that we need to pay attention to that because it is a dangerous environment to our mental health. The most important thing that you need to think about in terms of industrial safety is that you have a huge responsibility in addition to the responsibility that the healthcare organization has to keep you safe. It is not all one-sided. We had an interpreter come to an inpatient unit, and the nurse called me and said, would you get this interpreter off our unit immediately? He is behaving completely inappropriately. And I said, well, what did he do? The nurse said he came to the unit, found out from the front desk what room the patient was in, barged in, wearing his overcoat, carrying his attaché case, saw that everyone in the room had protective equipment on, turned around, walked back out of the room, now of course contaminated by whatever was in the room, back into the hallway, yelled at the nurse and blamed the nurse for not having protected him, the interpreter, from being exposed to germs in that environment. The interpreter clearly thought that it was solely the responsibility of the hospital to make sure that he, the interpreter, was safe. Not true. We have a responsibility as a healthcare worker to know the dangers and to take all of the precautions that we are trained to use to make sure that the environment does not become dangerous or does not hurt us or anyone else. So on all of these items that we're going to go through very quickly, there is an interpreter responsibility as well as an organizational responsibility to post notices and to let people know that there are hazards. We've already talked about the infection control area. The interpreter has a huge responsibility to practice safely. With radiation safety, yes, we have some very dangerous areas of the hospital. The interpreter has the responsibility of paying attention when the radiation technician is behind the little wall. The interpreter should be behind the little wall, not still talking to the patient. That's your responsibility. Mechanical safety is huge. We go running around from place to place. There is water on the floors sometimes. There is equipment in the hallways. We have interpreters who have slipped on floors, been very seriously injured, required numerous surgeries to repair their broken bodies. We have interpreters who have broken their toes by walking through corridors with lots of equipment stored along the sides of the corridors. This is a picture of appropriate interpreter garb. These folks do not have lots of scarves hanging off, wispy clothing, big sleeves, skirts that stick out a million miles. They have safe shoes. These guys, when they walk along in these shoes, they have good tracks on the bottom. They are not going to slip as long as they're not going too fast. They have closed-toed shoes. The ladies who have bare legs, I would say that that is pretty dangerous if there are any sharps being used in the rooms where they are, because if a scalpel falls on their leg or somebody jerks back from an immunization, it could still poke them pretty easily. And so I would caution against having that much exposed skin. Patients do fall on interpreters and on other healthcare workers. What I want you to think about here is be aware of unsafe patient conditions. Sometimes patients are left too long sitting on the exam table and they get dizzy and they start to fall. Sometimes they're in a wheelchair and they've got an umbrella that's going to stick in the spokes and they're going to dump out on their face. Bring that to the attention of the staff where you are working so that the staff can intervene and make sure that that patient is safe. Be aware of what your own limitations are in terms of being cold or hot or being able to stand for a long period of time. Wearing a lead apron is very, very heavy, and we have interpreters who cannot bear being in full lead for very long, and they should not accept those assignments. So just be responsible and let the staff, the other staff, know what your limitations are so they can work with you. We don't want you passing out and then they have to deal with two patients. The main chemical problem that you need to watch out for is probably formaldehyde on the countertop, because we do a lot of biopsies, taking little pieces of skin off of people and putting them in a formaldehyde container and putting it on the counter. And for some reason, these little jars tend to fall off, and then you've got formaldehyde fumes throughout the room. If you see something like that happen, get yourself and the patient out of the room, close the door, let the staff know. Do not try to clean it up. Physical danger from other people. At any time, a person can get overwrought and sometimes can hit somebody. When you hear voices go up, when you see behavior from someone, it doesn't have to be your patient, it could be anyone, that doesn't sound right, that you have concern about, get up, go to the staff and say, I'm the interpreter. I would just like to bring to your attention, I'm a little bit concerned about the possible for physical danger, or this person seems to be very angry, and I wanted to bring that to your attention. If you're with a patient in a room and there is anything that you're concerned about in terms of your physical safety, in a polite way but quickly, use the excuse, leave the area, and bring it to someone's attention. Don't wait in there until something happens. Generally, you want to be closer to the door than a patient, even if you're in there just for a moment with the patient alone. Very often we won't be in a room with the patient alone, but sometimes they step out just for one small thing and we're in there for a moment. Special rules about locked psychiatric units. Always brief with the staff before you go to the patient. Say, I'm your interpreter, what do you need me to know about this encounter? If you're carrying anything with you, leave it outside the room. Make sure you don't have anything around your neck that could be grabbed to choke you. Don't wear a lanyard that doesn't separate easily. Even if you have your name tag on, put that in your pocket. And follow the direction of the staff exactly. Be very alert to any signs of danger and act on it right away. If your patient is a prisoner, which will happen from time to time, do not be left alone with the prisoner, even for a moment. Guards need to go to the bathroom, that's fine, but you are not the substitute guard. You are not trained to deal with the prisoner. So if the guard is not next to the prisoner, you are not next to the prisoner. Do not have anything that you've carried in with you that could be grabbed by a prisoner to hurt someone. You leave that stuff outside the room, and you follow the instructions of the guard and the staff very carefully. You also do not tell the prisoner when his return appointment is, because then he could let that information be given to people on the outside to stage a jailbreak when he comes to that hospital again next time.
In general, I would discourage having your interpreter ID on a lanyard or anything that goes around your neck like a necklace. Get one of the clip-on ones that can go on your collar. And gentlemen who wear ties, I compliment you for wearing ties, but I would also encourage you to use the clip-on version as opposed to the knotted goes around your neck version for the same reason, whether it gets caught in equipment or whether it gets caught in the hand of somebody that's upset. You don't really want to give any advantage unnecessarily, and your safety is more important than your beautiful silk tie.
I love that. Don't give them a handle. Very often, family members or patients can act in an inappropriate way. We've had interpreters who had people fondle their bodies in elevators, who spit at them, who said really mean things to them, made them feel really bad, throw things at them, absolutely. So what we want to tell you is that it is your responsibility to bring that to the attention of the staff on the unit to remove yourself from that situation. You do not have to stay there. We want you to make sure to not stay there. So that is your responsibility. Once you bring it to the attention of the responsible people, then you have fulfilled your responsibility. Very often, something goes on. There could be a fire drill or a real fire or a real earthquake or something going on, and as the interpreter, it certainly wasn't, on your schedule for that day. What we need you to do is be clear with the unit what you are able and capable to do. If it's a real fire drill, the unit where you went to take care of your patient may not be able to reconvene for an hour, and you're supposed to be across town at the other hospital in an hour. Make sure that you help out to the extent that you're comfortable helping out, that you work with the staff, and that you let them know what your capabilities are and what's going to, make a plan with them about your patient, taking care of your patient. Interpreters are really in a lot of danger on the mental health side from their work. We are the voice of the patient. We are the voice of the doctor. Think of how many times a day that doctor has to give people bad news. and we're their voice. Think of, the terrible worry or pain that patients have, and we're their voice. We need to develop really good safety habits for our own mental health so that we can show empathy for each new patient as we go into a new appointment every 45 minutes. We need to be able to come fresh to each appointment. So we need to be able to debrief with people appropriately. Our families really don't know what we go through, so we just debrief very generally with them. So, yeah, I had a tough day. No, I had a great day. We had a couple babies born. That's great. Or it was a sad day. I had 2 patients die today. But that's about all we do with our families. But create good contacts in your own community of interpreters. If you're an agency interpreter, find some other interpreters. They're out there. There are thousands of us in the state of Washington. We are really good to debrief with, as are members of the care team, because we're all healthcare workers. This is our joint environment. And do good exercise, do good nutrition, have your own set of behaviors that helps you come back to base and back to equilibrium and find the good, and remind yourself that the work you do is so important and so appreciated.
Remember, as more and more companies come on board that offer remote interpreting, whether it's via telephone or video, face-to-face interpreting is going to get harder because the simple encounters are going to get triaged increasingly to remote modalities. So what's left for the face-to-face interpreter? It's end of life, it's sexual assault, it's emergency room, it's organ donation, it's mental health appointments, it's palliative care. It is a lot of difficult situations that will hit you with more frequency and as a result have a deeper impact on your own internal happy space. And so be mindful of that. Be mindful of how many people you had to give bad news to today, how many people you had to tell were going to lose a body part due to amputation, how many people you had to say you have this many more weeks left on this planet, and have a plan, whatever that plan is that works for you, your community that you're plugged into, the colleagues that you can debrief with, the exercise that you do, the activities that make you feel good, be they creative, be they athletic, be they family-oriented, or house of worship, or volunteering, or long walks with your dog. Find the thing that helps reestablish that equilibrium, because you need to incorporate that into your daily living in order to withstand the daily stresses that will become increasingly more challenging as more and more of the, I need to cancel my appointment, I need directions to this new clinic, those types of questions go to the phone. And return visits, glucometer checks, blood pressure checks, prescription refills, referrals to another provider, those often go to video. And what's left for the face-to-face interpreter is the really hard stuff. So you need to be ready to take on the hard stuff by proactively boosting the positive things that you do in your life to keep your emotional and physical health in good order.
Absolutely, and we need every single one of you, and we need every single one of you to be in great health.
No burnouts, please.
So, summary, again, healthcare is a highly dangerous environment. Healthcare workers have the responsibility to avoid risk and prevent injury and exposure to themselves and others. You are going to be given a quiz on this content by the LTC program. We wish you good luck, and we will see you out there.
Thanks for joining us.